Hi, my name is Mackenzie, and today I'm going to be talking about the role of implicit bias on Black maternal mortality and obstetric racism in the United States. Maternal mortality is defined by the World Health Organization as the death of a woman during pregnancy or as a result of pregnancy complications up to 42 days after giving birth. Though decreasing in recent years, maternal mortality is still a large issue of concern within the U.S., especially for African American women. In fact, in 2022, the CDC concluded that per 100,000 live births, Black women accounted for 49.5 of these deaths, while only 19 were observed for white women. This discrepancy can likely be attributed to a variety of structural inequalities within the United States healthcare system, implicit biases, and the role systemic racism plays within our country. In efforts to prove these claims within the following video essay, I argue that obstetric racism lies at the foundation of our country's high Black maternal mortality rates. I achieve this through a brief assessment of American history that primes the emergence of implicit racial biases and medical negligence, causing obstetric racism and high maternal mortality overall within the U.S. In order to understand the degree to which obstetric violence occurs within the United States, it is crucial to first understand the extended history of obstetrics and gynecological research in our country and the interactions they had historically with slavery. Obstetric racism extends all the way back to the 19th century and begins with a man named James Marian Sims, who was coined the quote-unquote father of gynecology. He earned this title by conducting a vast amount of gynecologic surgical experiments, mainly on Black enslaved women, and though they yielded numerous gynecologic discoveries in terms of medical knowledge, the experiments themselves were highly unethical and are a major determinant of maternal mortality modern day for African American women. Black enslaved women were chosen for Sims' experiments because at the time it was conceived that Black individuals had higher pain tolerances and tougher biologies. In her piece, Joli Hunt acknowledges that enslaved people were believed to have stronger bones, thicker skin, stronger immune systems, and a significantly higher pain tolerance than their counterparts of other races. And due to their enslavement, these women were not offered a choice and did not give consent to participate in Sims' experiments. These notions are also discussed within the anthology, The 1619 Project, A New Origin Story. The chapter on medicine addresses how these strength accusations have been proven to be false consistently. Numerous studies have emerged reinforcing that these claims have zero biological basis. However, they still appear in medical textbooks today, the textbooks that are being used to educate our country's future medical practitioners. This indicates that negligence is being practiced within our medical system, which creates an ideal environment for implicit racial biases to develop and take hold. An implicit bias is a type of unconscious bias that affects one's own actions and comprehension of situations, and in turn may negatively impact other members of society. Negligence is the failure to act or extend care in a medical setting, usually resulting from implicit bias in situations that practitioners without these biases would have acted upon if presented the same circumstances. This can occur through deliberate actions or omissions of care. The intentional and unintentional practice of both of these further exacerbate poorer health outcomes for Black Americans, not just in obstetrics, but across all fields of medicine. The reason implicit bias and negligence hold such dangerous implications on maternal mortality rates has largely to do with how practitioners perceive a patient's pain. Women's health is highly medicalized in the U.S., yet we have some of the highest maternal mortality rates of most of the globe's developed countries. According to MacDorman and her colleagues, studies found that 40% to 50% of maternal deaths were coded to ill-defined causes, meaning cause of death was unclear and not directly identifiable, which indicates they don't provide any information as to the actual cause of death. Why? Because patients report pain, but practitioners don't hear them, and more often than not, this phenomenon is racialized. This caused MacDorman and her colleagues to conduct a study in hopes to evaluate if these unidentifiable sources behind our country's high maternal mortality rates had anything to do with racial or ethnic disparities. For the unrecognizable causes of death, maternal mortality was 3.5 times higher for non-Hispanic Black women than non-Hispanic white women. For causes of death with attributable medical diagnoses, for example, eclampsia and preeclampsia, Black women are more likely to die from these as well. Eclampsia and preeclampsia are pregnancy complications that involve high blood pressure, seizures, and various types of organ damage. For example, lung, liver, brain, or kidney damage, to name a few. The data MacDorman uncovered determined that 60% of maternal deaths due to eclampsia were completely preventable. Maternal mortality rates for these causes of death were actually 5 times higher for Black women than white women, in contrast to the original 3.5. This undoubtedly indicates the presence of implicit bias and negligence within our country's medical system. Catching symptom onset early is crucial to the prevention of maternal deaths, but in order for this to happen, our system needs to reduce the impacts of implicit bias and address patients when reporting symptoms rather than brushing them off, as this tends to progress into negligence. Numerous sources identify that a lack of knowledge on issues such as implicit bias, negligence, and obstetric racism can actually lead to racial disparities in maternal mortality. In fact, educating practitioners on these issues can actually buffer maternal mortality rates and prevent adverse health effects. McCarthy explains this phenomenon in her piece. She explains this lack of knowledge and how it evolves into a determinant of adverse health effects by evaluating the intersection of two factors, the first being the experience of social death by Black mothers, and the second being the historical indispensability of Black women in the United States. As a refresher, social death is an extreme form of social isolation resulting from a lack of rights and failure to be recognized as human by society. This notion dates back to the times of slavery when Black mothers were stripped of their maternal identities and were overwritten by simply being enslaved. This social death was one of many strategies used to restrict Black autonomy. McCarthy describes how Black maternal social death combined with the biological indispensability of Black women, which is how they were believed to be biologically stronger, these interact and allow mere medical knowledge to not only be a cause of obstetric violence, but actually a determinant of death for Black women within the United States. This notion is also backed by MacDorman, who explains that mere knowledge of symptom onset was actually a major determinant of health for Black mothers who died from eclampsia complications. This works similarly for implicit bias and medical negligence. One cannot inflict change without first being made aware of an issue. To conclude, Black maternal mortality continues to be a major health concern for women across America, despite our country's accessibility to medical technology and economic status globally. The likelihood of maternal mortality is significantly higher for African American women than white women. Due to the research I presented, I believe it's safe to conclude that obstetric racism accounts for a large portion of the racial disparities evident within the United States maternal health outcome statistics. Our country's unsightly history with slavery continues to hold an impact in modern society. Stigma seeps into our medical system through implicit bias and unconscious medical negligence, causing adverse health effects for Black women. Thankfully, these consequences can be mitigated by educating practitioners on the ways in which these biases can take hold, as it's been proven that medical knowledge serves as a buffer for maternal mortality, not only in terms of implicit bias awareness, but also through acknowledgments of patient symptoms rather than brushing them off. Though gruesome, our country's history needs to be acknowledged in order to make effective changes throughout our structural systems. Should these measures be implemented within our country's medical education programs, we may begin to see a decrease in not only racial disparities in maternal mortality, but also in maternal mortality rates and obstetric racism in the United States as a whole.